Welcome to the deep dive. Imagine this. Medical innovation is just racing ahead. It feels like every day there's, a new breakthrough, maybe a new treatment, something that could really change lives. And naturally, everyone wants access. Patients, doctors. There's this huge pressure to get these innovations into the clinic, like yesterday. But here's the really tricky part. How do we decide? Responsibly, I mean. Which new technology should actually make it into everyday practice? We've had a tool for this for a while now, Health Technology Assessment, or HTA. It sounds solid, right? And look,
Okay.
it is valuable, definitely.
Yeah.
But it has some real limitations, especially when you're dealing with the kind of super fast evolving innovations we see today. So how do we fix that? How do we bridge that gap? Well, today we're going to introduce you to something called Constructive Technology Assessment, CTA. It's a different way of thinking, maybe more effective in some cases. Our mission in this deep dive is to, unpack why the old ways sometimes fall short. We'll introduce you to this dynamic world of CTA, and we'll show you how it's actually being used right now for things like new breast cancer treatments, getting them to patients better and hopefully faster. Should be some real aha moments here. Okay, let's unpack this then. For, decades now, health technology assessment, HTA, that's been the main way we evaluate new medical tech. And ideally, it's meant to be really thorough.
Yeah. And what's interesting is where it came from. HTA actually started more in business and public policy circles before healthcare really picked it up. The original idea, the formal intent, was always this broad assessment looking at everything organizational stuff, social impact, economics, ethics, the whole picture.
Right.
When it moved into healthcare, maybe back in the 70s, the goal was to support these really complex, holistic decisions about bringing in new tech. Not just, does the science work?
That sounds incredibly comprehensive, that original vision, like a full 360 view. But you said original intent. What often happens in practice? Given all the pressures in healthcare, what gets sort of left behind?
Well, that's a really sharp question.
Yeah.
Because in practice, despite that broad initial scope, HEA often gets, narrowed down a lot. Policy pressures, budget constraints, they often mean it boils down to basically two key things. Clinical efficacy, does it actually work in trials?
Mm.
And cost effectiveness. Is it worth the money? Now, every country tweaks HTA for its own system, sure, but this narrower focus is pretty common. And it can miss that wider real-world context. How does it really impact patients, the system, beyond those 2 points? And this leads us straight into a core issue, something researchers call the paradigm of stability.
Paradigm of stability, okay.
Yeah, it sounds academic, but it's crucial. The way HTA studies are often designed, they rely on this assumption. It's often unspoken, but it's there called the ceteris paribus principle.
Ah, the old all other things being equal.
Exactly. It assumes that during the whole assessment, which can take years, both the technology itself and its environment, how it's used, who uses it, all that stays perfectly still, stable.
Wow. Okay, I can immediately see the problem there for modern healthcare. Nothing stays stable. Research keeps coming, practices change, patients have different expectations.
Precisely. It's a fundamental mismatch with today's reality. Technologies evolve, sometimes rapidly, and the environment around them, how clinics are organized, how things are funded, patient reactions, even the legal and ethical landscape, it's all constantly shifting.
So the assessment is like taking a snapshot of something that's already moved on.
You've got it. And the consequence is pretty significant. Those HTA results, sometimes they end up having, and this is a direct quote from research, limited impact on practical implementation and on coverage decisions.
Why? Just because they're old news by the time they come out?
Pretty much. These studies can easily take 6, maybe 7 years, from designing it to actually publishing the results.
Then.
Often outdated. Clinicians might have already found newer studies, developed their own informal guidelines, adapted how they use the tech. The formal assessment arrives late to the party.
Right, so this paradigm of stability wasn't just an academic point, it was creating a real gap. Did systems start to notice? Did they try anything different?
Oh, absolutely. People recognize this disconnect.
Ah.
A really key example is back in 2005, the Centers for Medicare and Medicaid Services, CMS, in the U.S. They did something pretty innovative.
Okay.
They introduced coverage with evidence development.
Yeah.
Basically, they said, okay, this technology looks promising. We'll start covering it now, even without the final definitive trial data. But, and this is the crucial part, it came with strings attached.
Ah.
Yeah, providers and patients had to participate in ongoing research, data collection, registries. It was a clear signal. We need ways to assess while things are happening, dynamically, not just waiting years for a final verdict.
So sticking with that old static approach meant, promising innovations could get stuck. Assessment limbo, you called it. Or they get introduced maybe haphazardly, without the best guidance.
Well,
That affects everyone, right? Especially you, the patient, waiting for a breakthrough, which makes the need for something different really clear. So how does this other approach, constructive technology assessment, CTA, how does it change the game?
right, CTA is a fundamentally different mindset.
Yeah.
It actually emerged back in the 1980s, and interestingly, not initially in healthcare. That's kind of important.
Okay.
It evolved from just trying to measure the final impact of a technology to looking at the whole life cycle, analyzing its design, how it's developing, how it's being implemented right from the get-go. It's about being, well, proactive, shaping things.
Oh.
If you think about the bigger picture, CTA isn't just about observing effects from the outside. It actively acknowledges and tries to leverage what we call sociodynamic processes.
Sociodynamic, meaning?
It just means all the complex interactions, right?
Yeah.
Between the technology, the people using it, the organizations, the patients, how all those things influence each other and change over time. CPA deliberately tries to influence the design and implementation process to make the technology work better in the real world. It's moving from being a passive judge to an active, constructive participant.
That sounds really different. Intentionally influencing design. Some people might worry that compromises neutrality, doesn't it? Is the idea to replace HTA?
That's a fair question, the neutrality point.
Yeah.
And no, it's definitely not about replacing HTA. Think of it as complementary. CT is particularly powerful for technologies that are introduced at an early stage of their development, but in a controlled way.
Ah, okay.
It lets you guide and refine things as the technology is actually finding its place, something traditional HTA with its fixed assumptions just can't do. The influencing part isn't about skewing scientific results, it's about optimizing the process of getting it into practice effectively and safely. And CTA really embraces the dynamics we talked about. It explicitly considers the different phases of how tech spreads, using models like Rogers diffusion theory.
Right. The innovators, early adopters,
Yeah.
that whole curve.
Exactly. Innovators, early adopters, early majority, late majority, laggards. CTA acknowledges that a technology isn't adopted uniformly. So the assessment approach gets tailored to where the tech is on that curve. And critically, it often starts before the technology is even widely available. It's learning and adapting right alongside the innovation's journey.
And you mentioned HTA often narrows down to efficacy and cost. Does CTA manage to keep that broader view you talked about earlier, the social, ethical, organizational stuff?
Absolutely. That's a key difference. CTA, almost by definition, takes that wider panoramic view. It recognizes that a technology's real value isn't just clinical numbers or cost savings. It dives deep into the patient perspective.
Like what?
Things like social impact, ethical considerations, patient acceptability, psychological effects. How patient-centered is it really? And it scrutinizes the organizational side too.
Meaning, like, how easy is it for a hospital to actually use it?
Exactly. How easily does it fit into existing workflows? What new skills or training are needed? How does it spread between different departments or hospitals? Is it accessible to everyone who needs it? This holistic view means you're evaluating not just a thing, but how that thing actually changes care in a complex, dynamic system. You try to spot potential problems early.
Okay, so it's holistic, it's dynamic. What about the how? What methods does CTA actually use? Is it just talking to people?
Oh no, it's a much richer toolbox than that. It does use traditional social science methods, surveys, interviews, observations, sure, but it combines them with approaches really specific to CTA. Things like detailed process analysis, measuring patient satisfaction over time, tracking real-world impact. And one method that's particularly important for CTA, especially for handling that dynamic aspect, is using scenario methods.
Scenarios, like what-if planning?
Sort of, but it's more active than just planning. These scenarios are used for ongoing monitoring. How is implementation actually going compared to our plan? They help identify new evaluation needs as they pop up. And, crucially, they can even be used to intentionally steer the development or implementation process if things are going off track. It allows for that real-time course correction.
Okay, this is making sense. Let's make it concrete. You mentioned a real-world example, applying CTA to a cutting-edge technology in breast cancer. Tell us about that.
Right, this is a great case study. It involves microarray analysis, specifically a 70-gene expression profile.
Microarray analysis. Break that down for us. What is it in this context?
Sure. So, at its heart, microarray analysis is a lab technique. It lets scientists look at the activity of thousands of genes all at once from a tissue sample. Think of it like a tiny chip giving a snapshot of which genes are switched on or off. In this specific breast cancer case, research back around 2002 showed that looking at a particular set of 70 genes, this 70-gene profile could predict the chances of survival in certain patients, those with node-negative breast cancer. And importantly, it seemed to do it better than the standard clinical factors used at the time. It helps assess the risk of the cancer returning elsewhere in the body, typically within 5 to 10 years.
So not just a small improvement, but potentially a real step forward in personalizing treatment. How does that work for an actual patient?
So in practice, after a patient has surgery to remove the tumor, a sample of that tissue gets sent off to a specialized lab. The lab runs the microarray analysis. Then the oncologist gets the result back, this 70-gene profile signature. It basically categorizes the patient's prognosis as either good or poor. And that information is then used to help decide on the next steps, specifically about adjuvant systemic therapy, things like hormone therapy or chemotherapy.
Right, so it helps tailor the treatment, avoid chemo if the risk is low, or make sure it's given if the risk is high.
Exactly. It's about getting closer to the right treatment for the right patient, potentially sparing some patients from tough side effects while ensuring others get the aggressive treatment they really need.
Okay, so incredibly promising technology, personalized medicine in action. What was the holdup then? Why wasn't it just rolled out everywhere immediately using the standard HTA process?
That was the big dilemma. The retrospective data looking back at past cases was really strong. But the traditional path to prove it definitively for widespread use, that meant massive long-term prospective clinical trials. We're talking at least 10 years.
10 years.
Yeah. And that's a long, long time to wait if you're a patient today who could potentially benefit from this more accurate risk assessment. It created this real tension. How do you balance the need for rigorous proof with the urgency of patient need, especially when the tech seems ready?
And this is where CTA came into play. What did they do differently?
Precisely. The Dutch Healthcare Insurance Board saw this exact problem. They'd already set up a program specifically for the controlled introduction of promising innovations like this, ones that were still in early stages. The microarray case was basically a perfect candidate for CTA.
So the goal wasn't just, is this effective,
Yeah.
but something more.
Exactly. The goal was much broader, to ensure and actually improve the quality of how these microarrays were implemented in breast cancer care while they were being introduced. Not waiting 10 years, but learning and improving in real time.
So how did they operationalize CTA? It was a really smart, phased approach. They knew the technology was in that early stage innovation, maybe early adopter. So they started small with a clinical pilot study.
Okay, not everywhere at once. Right. They planned for what they called stage diffusion. Began with just a handful of hospitals, maybe up to 6, the innovators. This let them really test logistics, see what practical problems cropped up, work out the kinks. The plan was always to gradually expand to more hospitals, mimicking how innovations naturally spread, but doing it under this careful observation umbrella.
That makes sense. Learn as you go, adapt the rollout. And which specific aspects did the CTA focus on in this case? Was it just the clinical outcome?
No. Consistent with the CTA philosophy, they looked broader, and crucially, they looked at changes over time in these aspects. They focused on things like patient-centeredness. How did patients experience this? Was it understandable? Did it meet their needs? User-friendliness for the clinicians involved.
Right.
Timing when in the treatment pathway was the test most useful. Efficiency and, yes, efficacy.
Right.
But also juridical and ethical aspects, informed consent, data handling, things like that. And safety.
What about cost effectiveness? That usually comes up.
It does, but they plan for that to come later.
Yeah.
Cost effectiveness studies need more robust, real-world data on how things actually play out.
Yeah.
But the idea was gather that data during this controlled implementation phase and then do the cost effectiveness analysis once you had a better picture. The focus initially was on getting the implementation right, and they started with something they called a zero-base measurement. Think of it as a really thorough prep phase. Before even introducing the test in the pilot hospitals, they gathered tons of information.
How?
Through literature reviews, analyzing hospital documents, actually observing current practice, and doing detailed interviews with oncologists, surgeons, pathologists, nurses.
Yeah.
Everyone involved. This wasn't just data collection for the sake of it. It was about understanding the baseline, identifying potential hurdles before they happened, and using all that to create an initial guideline for how to implement this effectively.
Proactive, okay. And then came the monitoring.
Exactly. That was the second phase, the monitoring phase.
Yeah.
As the pilot hospitals started using the 70-gene profile, the CTA team monitored them closely. How were they actually applying it? Was it matching the guideline? Where were they deviating and why?
And they'd feed that back.
Immediately. Deviations weren't seen as failures, but as learning opportunities. It allowed for rapid feedback, refinement of the guidelines, maybe additional training if needed. This ongoing monitoring, combined with the prospective validation data being collected, is what then built the foundation for those later cost-effectiveness studies.
It's really quite remarkable when you lay it out like that. CTA essentially allowed this technology to start benefiting patients years earlier than the traditional route, but not in a reckless way. It was done carefully while simultaneously improving how it was used.
Yeah, it highlights that dynamic learning aspect,
Mm.
which leads to the question, well, when is CTA the right tool? It's not for everything, presumably. It seems particularly well suited for these promising technologies that are still in relatively early stages of development, especially when there's still some uncertainty about exactly how they'll be used or when you expect a lot of back and forth. That dynamic interaction between the technology and its environment, the clinicians, the patients, the system.
So maybe less for a straightforward new pill where a classic trial design works well, but more for technologies that are complex to integrate.
I think that's a good way to put it. Traditional drug trials often fit the classic randomized controlled trial, the RCT model, quite well. CTA shines more with, say, hard technologies, maybe a new kind of implantable device like an assistive heart pump, or soft technologies like implementing a new quality management system across a hospital, or even mixed things like telehealth or e-consulting platforms.
Things where the human and organizational factors are really key.
Exactly. Anything where the technology interacts intensely with its environment and practices, and where that interaction itself needs to be understood and potentially shaped for success. It's also worth mentioning how it relates to other methods that handle dynamics. Bayesian methods, for example, are also dynamic. They update probabilities as new evidence comes in.
Right.
But Bayesian approaches often need a pretty solid base of existing data, especially on cost effectiveness. Just to get started, CTA can be more useful in those really early phases, the innovation or early adopter stage, where that foundational data might just not exist yet. CTA helps generate that initial real-world evidence in a structured way.
Okay, it sounds like a really valuable approach, balancing speed and learning. But nothing's perfect.
Okay.
What are the challenges? Does CPA face hurdles?
Oh, definitely. There are challenges. A big one can be clinician buy-in.
Why is that?
Well, clinicians are, understandably, very evidence-focused. They're often more comfortable with and trained in interpreting classic HTA designs, especially RCTs. Those are the studies that traditionally get published in the top journals, the ones they trust. Moving away from that ceteris paribus's stable world assumption can feel, well, less rigorous to some initially.
I can see that. If you're used to the gold standard RCT, something more fluid might seem less solid. How does CTA address that? How do you get doctors on board?
That's where involving them early and showing the practical benefits really helps, like in the microarray study. By bringing clinicians into the process right from the start, by making them part of identifying problems and refining the implementation based on their real-world experiences, maybe tweaking logistics, improving patient communication materials, you build commitment. They see it's not just assessment of them, but assessment with them to make things work better.
Okay, so involvement is key. What about the researchers themselves? If they're so involved influencing things, helping refine the process, does that risk their objectivity? Could they start seeing what they want to see?
That's a really critical point, and yes, it's a potential risk that needs managing carefully. That close interaction is necessary in CTA to really understand the day-to-day realities and the changes happening. But you're right, it could potentially bias interpretations.
So how do you guard against that?
CTA relies on pretty robust safeguards. Standardized measurements are key, using consistent tools and metrics across sites and over time. And, really importantly, verification by other researchers, independent researchers, at each stage of the process. It's like having built-in checks and balances to compensate for not having that traditional detached study design, especially in those early, more fluid phases. Objectivity is maintained through process and validation.
So bringing it all together, what's the big takeaway for, anyone listening, whether you're a patient, maybe a policymaker, someone working in healthcare? Why does CTA matter?
I think the key takeaway is that CTA offers a way to navigate that tension between speed and carefulness when it comes to innovation.
Yeah.
It provides a structured approach to bring promising technologies into practice, potentially faster, more effectively, but also more thoughtfully, because you're continuously learning and optimizing the quality along the way.
And it can directly feed into policy, too.
Absolutely. It gives policymakers, like those insurance boards or health ministries, the kind of real-world evolving evidence they need, especially as more and more places explore these coverage with evidence development or early access schemes. It helps make those decisions less of a leap of faith.
Okay, and that feels like a good place to wrap up our deep dive for today. We started by looking at the challenges with traditional health technology assessment, that paradigm of stability struggling in such a dynamic field. Then we explored this alternative, or maybe complementary approach, constructive technology assessment, more proactive, adaptive, looking at the whole picture. And we saw it in action with that really powerful microarray analysis case study in breast cancer, getting vital diagnostic information to patients years sooner while making sure it was implemented well. The story of CTA really drives home that assessment doesn't have to be just a final judgment, a static snapshot. It can be an active, ongoing process of shaping and improving innovation as it unfolds. It kind of makes you wonder, doesn't it? How many other breakthroughs might be out there, maybe held back by older assessment models? And how can we use approaches like CTA to make sure they reach the people who need them, not just faster, but better? It certainly suggests a powerful way forward, thinking about not just what a technology is, but what it truly becomes when it meets the real world.